Hi, this is Dr. Purcell. I want to just go briefly over the self-learning module for the psychotherapeutic drugs that we were covering for our module on this, and that's fluoxetine and dualoxetine. What I show you here on my screen is the chapter 16 in our Lilly textbook, but I'm keeping it open to the area on the left, the table of contents, because I want you to just notice that chapter 16 is located within the section on drugs affecting the central nervous system. Right now, you should realize these psychotherapeutic drugs are in the unit on central nervous system drugs. They are going to affect our central nervous system. So let's see if I can close this without. There we go. Perfect. I always mess it up whenever I try to do this while I'm recording. Let's talk about a couple of the key terms here you might like to familiarize yourself with and in order to understand them within the context of this chapter. So anxiety is determined here to be the unpleasant state of mind in which real or imagined dangers are anticipated or exaggerated. And depression is separate. I mean, it's an abnormal emotional state. And you can read on here about the exaggerated feelings that are described here. As we come down, next page, the next one you'll want to know is the difference, between what I just pointed out, anxiety, depression, and now psychoses. And because the drugs that we are going to focus on in this chapter are specifically designed for the depression and anxiety type of area, they are not used in treatment of psychosis, which is a serious mental illness. It's basically a break with reality. Now, there are drugs in this chapter for dealing with that. And so remember, when you are in next semester and you're taking your psych mental health class, come back to your Lilly textbook to help you learn about the other drugs that are used for other types of mental health and illness for psychotherapeutic uses. One last definition here is serotonin syndrome. And to understand that it's a collection of symptoms. It's not one thing, so it's a syndrome. It's all series of symptoms that results from elevated levels of the neurotransmitter. Guess what? Serotonin. That should have been like a no-brainer right there. This can occur with the use of any psychotropic drug that enhances serotonin activity. And the two antidepressants that we are going to be focusing on are actually drugs that can cause serotonin syndrome. So you'll want to know that. And you'll see it says C-Box 16.1. So you will want to make sure you take a look at that. Although you could go straight to the fluoxetine, which is here, by clicking on that, or to the, where's our dualoxetine here? By clicking on that, you will want to first read through the overview and some other information here at the front, and then go and look at our drugs that we want to look at. And it's really important for you to read this because you haven't had the background yet in the formal psych mental health background. So you need to understand a little bit. Look, it's like basically just a couple of paragraphs right here. But then they start going into what psychotherapeutics are. So it's not a huge amount, but it's just enough to help you understand why we would give these drugs and how they work. And one of the things that's really important for you to see here is that the exact causes of mental disorders are not fully understood. So when you come in here and you're trying to look at the mechanism of action for the drugs that we're going to be studying, it may say, we don't know. We don't know the mechanism of action. And that's all part of the nature of dealing with the psychiatric and mental health disorders. Remember, I told you about anxiety and oops. Oh, I clicked it and now I've lost. Oh, no. Good, it came back. Anxiety and depression. And here they are. They are discussed a little bit more. And then we start getting into the pharmacology. And you'll want to look at that, just this one little section. You need to read that. Now, the anxiolytic drugs are here in this table, and you can see none of ours are here. So now you can skip that section. Let's come on over. And then we go into benzodiazepines. We're not covering those. You will want to come back and learn about those, especially in med-surg. You'll be using those. Needed some drink of coffee right there. Sorry, guys. These are pretty common drugs. You may even want to look at them because you know somebody who's asked you about them or they're taking them. So the list of antidepressants is in table 16.4. And if you look, mood stabilizing drugs are also in table 16.4. Interesting, huh? Mood stabilizers and antidepressants. You think our drugs might be in there? They just might. Let's find out table 16.4, and then you'll know whether or not you need to read that section. And we have, second generation SSRIs, and we have our fluoxetine here and our duloxetine. So let's go on back. We do need to read that section. So you'll want to cover the part about mood stabilizing drugs. Well, a little bit. Lithium was probably one of the first ones that came out. You'll really learn a lot about that in psych mental health. But it has if you see here, narrow therapeutic range and requires blood level monitoring. That makes it not a favorable drug to use in this setting. And it then points you on to table 16.4 for the better drugs. So now we pop on over here to our antidepressant drugs. And this is where you'll start to read about the SSRIs. So I just flipped the page. And here it talks about, it postulates the theory. There's theories about depression. We don't even know exactly what causes it. We know that it's some sort of a chemical imbalance, which then leads to problems with neuronal and synaptic catecholamines and functioning. And so then there's another hypothesis called the permissive hypothesis and dysregulation hypothesis, and some pictures there. Understanding that little bit is going to help you understand your drugs a little bit better. Primary goals. You see something that says the primary goals. Oh, wait, let's back up. Research indicates that early and aggressive antidepressant treatment increases the chances for a full remission. So what increases the chances for a full remission? Early and aggressive treatment, which means identifying early, not waiting until somebody has such a deep depression that they are actually considering taking their life. We want to get there early. But this is going to be the important thing for you to notice. As a nurse, the first 6 to 8 weeks of therapy are the acute phase. And the primary goals during this time of the acute phase is to obtain a response to drug therapy and improve their symptoms. It's currently recommended that antidepressant drug therapy be maintained at the effective dose for an additional 8 to 14 months. They shouldn't just stop just because they felt better in those first weeks. Here's how you measure therapeutic response. Remember, I'm always going to ask, how do you know if the drug is working? Well, in this case, therapeutic response is measured primarily by what the patient tells you about how they're feeling. And in psych mental health, there will be you'll learn about some checklists that can be administered before, during, and later on during treatment to sort of have an objective view towards whether or not the drug or the therapy is working. But for the most part, we have to rely on what the patient tells us. I'll come down here. Okay, I want you to notice that there are black box warnings. on all classes of antidepressants in both adults and pediatrics. So that means, I've told you, I've kind of mentioned that the two drugs that we're going to talk about and learn about in this module are second generation antidepressants. Yes, there were some first generation, and they were the best that we had until the second generation ones came out, and they're much better. But it doesn't matter if it's first or second generation, the black box warning is going to apply to all classes of antidepressants. And here is why. Because you might say, why? What's this black box warning? Because data from the FDA indicated a higher risk for suicide in patients receiving these medications, which almost seems counter to what it should be doing, right? But because of that, the current recommendation is that for all patients receiving antidepressants, we include regular monitoring for signs of worsening depressive symptoms, especially when the medication is started or dosage is changed. So that is the problem, is it's in those first few weeks is when this black box warning and the risk for suicide is the highest. It's when the medication is started or a dose is changed. So that's when nursing needs to be really acutely aware that their patient is high risk for suicide. And then the book starts going into the tricyclic antidepressants and their use, as it even says right here, has largely been replaced with the SSRIs. So we are actually going to focus on SSRIs and not tricyclics. Let's keep going until we find our little SSRIs. No, not the monooxidase inhibitors. Where's our little SSRI section? Second generation antidepressants. Here we go. So it tells you here that antidepressants were introduced in the 1980s and continue to be introduced today. So there are more that keep coming out to market. They have come out with, they're still second gen, but they're the drug companies are finding more and more that are probably a little bit better and have fewer side effects. They're considered superior to the tricyclics and the monoamine oxidase inhibitors because their adverse effect profiles are so much better. And having significantly fewer side effects means the patients are going to stay on them, and you want to treat your anxiety and depression, but you don't want to take a drug that makes you feel so bad that it's worse than your anxiety and depression. And so these drugs actually have a very tolerable adverse effect profile. Now it's going to go on to mechanism of action and drug effects. And we know that the inhibition of serotonin reuptake is the primary mechanism. Although the SNRIs inhibit reuptake of both serotonin and norepinephrine. And then, the indications here, pretty straightforward for you. And actually, let's see if they're on here. With our norepinephrine, SSNRIs, some pain related, like fibromyalgia, for instance, and even some rheumatoid arthritis, some other pain related problems are helped by taking SSNRIs. And I was looking to see if they were on here, but I don't see them. It does say it's ever expanding. The contraindications would be, of course, a drug allergy. They can't currently be taking a monoamine oxidase inhibitor, and they need to have at least 14 days free of those drugs before they start on one of these. And there's some other couple things here, but more importantly, just not to be given with the MAOIs. Goes on and talks about the adverse effects. Most common, insomnia, which does seem to resolve. There is some weight gain, which people don't like, but that can be managed as well. And the sexual dysfunction isn't so much like erectile dysfunction, but rather the inability to achieve orgasm. There is a potentially hazardous adverse effect, and that's the serotonin syndrome. And it's actually sounds worse than it is. here's the symptoms, the common symptoms, and serotonin syndrome, people are at risk for this when we up their dose of drug, and sometimes at the onset of therapy, but also we usually start low and then increase the dose of drugs so that those adverse effects that we have up here can be managed a little bit easier. So we might start at 30 milligrams and after a few weeks go up to 60 milligrams and maintain at 60. But it's when we go up on the dose that we might see the serotonin syndrome. And so these are some of the symptoms that you can see here. The patient is going to come to you. They're not going to come to you and say, I have rhabdomyolysis, I have renal failure, I have seizures. They're going to come because they have agitation, tachycardia, sweating, shivering, and they just don't know what's going on. They may even go to the emergency room. And that's when, finding out what medications are you on and identifying that there's a SSRI in there. And the way it's treated is really, really easy. Fortunately, serotonin syndrome is self-limiting upon discontinuation of the causative drug. So as soon as we stop that drug, we will stop seeing the symptoms of serotonin syndrome. So what you want to know is, what's the half-life? What time did you take it? What's the half-life? How long can we expect the drug to remain in your system? Because once it's out of your system, the serotonin symptoms will go away, and we just won't give you that drug anymore, or we'll reduce the dose. Oh, look at this. It's talking about half-lives. So those with the shortest half-lives are the most commonly associated with a discontinuation syndrome, which is this next line here. They're associated with discontinuation syndrome or withdrawal syndrome. And so for that reason, we tend to slowly taper people down off of SSRIs. This is a different thing from serotonin syndrome. This is withdrawal syndrome. This is why we don't like people to be off these medications for more than actually 12 hours. They need to be taking these every day. There's some symptoms here. It's not pleasant, but as you can see, it's not, the drugs that we're studying are not even really associated with that. It says it mostly occurs with the SSRIs, but it can occur with the SNRIs, and what ours is dualoxetine. There are also drug interactions that can happen. They are highly protein bound to albumin. So we need to be careful when we're giving other highly protein bound drugs such as warfarin, phenytoin, because they're going to compete for the binding sites. When they compete, the result is one of these drugs is not going to bind to albumin as much as it should. So now you have free unbound drug. And so you're going to have more pronounced drug effect. So it could be the SSRI that's more pronounced. It could be the warfarin, the phenytoin, but basically that is going to be managed by our provider in conjunction with the nurse, helping to understand what types of drug effects are being seen. You can read the part about the MAOIs. That is pretty much for anyone who's on MAOIs, not just someone who might start taking one of these second-gen antidepressants. And now it'll tell you some of the drug profiles. There's our, fluoxetine is not one of ours. Dualoxetine is ours. It's our SSNRI. Here's some adverse effects. It's only oral use, which makes sense because it's a maintenance drug that people take at home, not in the hospital. They don't come to the hospital to take it. And then our other drugs should, I didn't see it. Oh yeah, wasn't it right there? Fluoxetine, I think it was at the top of that page. There it is, our fluoxetine. It was the first SSRI marketed for treatment. It was a breakthrough for a lot of people, but its indications have expanded beyond depression. And so now it's even used in bulimia, OCD, panic disorder, premenstrual dysphoric disorder, and so on. And that is the coverage of the drugs. We're not going into the antipsychotics, and we should be coming up here onto the nursing. And administration of these drugs. Look, there's even more. It's a big chapter. And you do want to come back to this when you're in psych mental health. So now it's going to talk about assessment. And remember this, you see how big the chapter is. There's a broad range of drugs, a broad range of psych mental health diseases. And so focus when you're reading about this, just focus in on the anxiety and depression and those who would be candidates for taking the second generation, not anybody that has schizoaffective disorder or psychoses or anything like that. And then probably look at, we're not doing anxiolytics. Trying to see what else we have here. Here's our antidepressants. So here you are in the nursing administration section. This is what you as the nurse need to know. And I can tell you now, yep, there it is. Continuous assessment for suicidal ideation or tendencies, because these could be overt or covert. And it's always a potential risk with psychotherapeutic medication. And we talked about that just a minute ago with the black box warning. And then it goes into the TCAs, which we're not covering, the MAOIs we're not covering, and then here's your second generation antidepressants. Here's where you want to focus your reading. I'm sorry, I felt that sneeze coming. I couldn't stop it. And then we have our human needs statements. Again, we're going to come in here. You want to just review what's appropriate here for you under implementation when it comes to your second gen SSRI or your second generation antidepressants. And then it's going to go into evaluation, monitor for therapeutic effects. And again, find in here, here's your, when used as antidepressants, may take 4 to 6 weeks to reach full therapeutic effect. So somebody who's not going to feel better within 1 or 2 weeks, and they need to know that. That's nursing's responsibility if they're there when the drug is ordered, but it's our responsibility to make sure that the person knows they're not going to feel better immediately, that we need to wait a few weeks, keep taking it, don't stop taking it. You've got to keep taking it, get up to a certain blood level before we start seeing the full effect. And then it tells you the second sentence after that, or the next sentence tells you what you would see for a therapeutic response. So if I ask you, how will you measure therapeutic response? And it tells you right there how you're going to measure that. And I think that should bring us near the end of this chapter. Now, important for you to look at is the patient-centered care and patient teaching, specifically here with our SSRIs and our SSNRIs. And it has some stuff here about fiber supplements that affect drug absorption. Openly discuss concerns that they may have, because if they don't, they may just stop taking the drug, which is not helpful. Imparting to the patient how important it is that they need to be taken carefully and as prescribed, keep follow-up visits, and so on. You can read that. Here's some key points, and that should bring us, pretty much to the end. Let's look at, I see right now, number 6, this question here. Let's look at this. A nurse is teaching a patient about treatment with an SSRI. Which teaching considerations are appropriate? Now this with tyramine would be the MAOIs. Use caution when standing up. The patient should not take products. Yes, C, I would say, is probably one of the answers. Do not stop this medication abruptly. And I would check before taking over-the-counter medications. Now let's see if the answers down here. All the answers are online. Oh no, see page 908. Okay, for number 6, Dr. Purcell chose C, D, and F. Let's see if I got it right. For number, oh gosh, what chapter is that? 16. Number 6, it's B, C, D, F. Oh, okay. So, let's see if we can go back easily to 271. Does it do that? It does. Wow. Okay. I said B, C, D, F. I'm sorry, the answer is B, C, D, F. Okay, so the one I didn't pick was B, which is they need to be instructed to use caution. That's because I didn't read that section. But right there, it's pretty close. I was pretty close. I would have missed that question. And I don't see any others in here specific to our drugs. That was the only one. All right. Well, I hope that this helped you understand a little bit about how to approach your understanding of these two drugs and what the nurses need to know when caring for a patient on these drugs and providing information to a patient on these drugs. Have a wonderful day and happy studying.